Hi everyone, and thanks for joining us today. We are bang on 1 o'clock, so to everyone who's already joined, welcome. We'll just wait for a few more people to join us. But while we wait, I'll just introduce myself and my guest. As you can see, it's not just me today. I'm Emily. I am the content manager at Birdie Care, and I will be your host for today's webinar session. Now, like I just said, it's not just me. I'm joined by Debbie Ripley of Marie Curie, which I'm very, very excited about. And we're going to be chatting all about palliative care and how to upskill your teams in this area. So I'll let her introduce herself properly in just a moment, once we've had some more joiners, as I'm sure they wouldn't want to miss that. But while we're waiting, if you can just let me know if you can hear me okay, and pop a note into the chat box to say hi. You can put an emoji in there, whatever you want, just so I know that you can hear fine. And Debbie, if you wouldn't mind as well, just saying a quick hello and make sure everyone can hear you too, that would be great.
Hi everybody, my name's Debbie Ripley. I'm the Regional Manager for Marie Curie Nursing Service in the community across London. Nice to meet you all virtually.
Perfect, thank you. Oh, we've got quite a few people saying hi. I can see you all waving and saying hello. Hi Anna, hi Jane, hi Maud. Wow, loads of you today, this is great. Thanks for joining us on your Friday lunchtime. Perfect. Now, if you haven't joined me for a webinar before, welcome. And if you have, welcome back. Thanks for joining me again. And what I'll do now is I'll just run through setting the scene and what you can expect from today before I let Debbie really get into this. But before I do that, if you have any sound issues, which it seems like nobody does at the moment, but if you do during the session, put a note into the chat box and I'll do my best to sort that for you. We have some of the team on standby and they are much more techie than I am, but I'm sure they can help out. So do let me know if you have any problems. Now, first things first, what we're talking about today is palliative care. And many of you will already be providing this, you already know a lot about it. And this session today is really about helping and supporting and giving you some resources that you can use straight away. So the reason that we thought this was important is because, you know, the big C word, COVID, it's been everywhere. And obviously it's changed the way that we care. Lots of things have changed as a result of it. And now what we're seeing is a huge, huge preference for care in our own homes. And we're seeing that many people want to remain at home rather than choose a care home or, you know, be admitted to hospital. And Debbie will be talking to us a little bit more about the impact of COVID on palliative care a bit later. So I'll be really brief here, but this is kind of setting the scene for today and why we think it's so important to bring this to the forefront. And as I said, many home care agencies already are providing palliative care. And the reason we're here today is not to tell you how to do it. It's to help you get hold of some support resources and find all the training and upskilling that you need to really keep continuing delivering the best care. And one thing that I just wanted to call out here was a quote I found on the Marie Curie website. And it says, palliative and end-of-life care is an under-researched area. There are many unanswered questions to be addressed, yet resources are limited. And the reason I wanted to highlight that is because today we're here to give you resources, so hopefully we can help. And another point to make before we launch into our Q&A is if you have any questions about anything that we're talking about while we're going through, please do put them into the chat box and I'll try to get to them while we're talking. If I can't quite get to them while we're having our conversation, we do have some time at the end for a Q&A. So do make sure that anything comes up, just pop it into the chat box and we'll try and get to it. Great. Now, I think most people have joined us, so I will say let's launch on into our Q&A with Debbie. I know you're here to hear from her and not me. So the first things first, Debbie, is you just gave us a very brief intro, but can you just tell us a bit about how Marie Curie helps?
So Marie Curie are a charity. So you probably know we used to specialise in cancer care, but now a few years ago, we've embraced all types of kind of life-limiting illnesses. So anybody who's dying of heart failure, of respiratory disease, dementia. All of those things now kind of come under the charity's kind of support structure. So we started the same year as the NHS, interestingly, and we started with some hospices, and then obviously we grew into having community services. So what we hope to bring to the table is some experience, and we've also got a lot of free resources that are underutilised, and an information and support line which is all free for patients, for family, for health and social care professionals. And that's really why Emily invited me to talk to you today, because we know what a great job you're doing, providing care in people's homes. Then actually you need to know that there is all this resource out there that's free as well. We don't currently offer any formal training, but of course, that is something we are looking at. But today is just to kind of show you what we've got, and help any way we can, improving what you're already doing.
Amazing, thanks, Debbie. And again, it's probably something that a lot of people aren't aware of, how much there actually is out there from Marie Curie. So hopefully we can go through just a few of them today and really, really help. So thanks for that intro into what you do and how it works with Marie Curie. And the main thing I think we're covering today, of course, is what is palliative care. Now, as I mentioned, a lot of people already know, but I think it would be good just to get your kind of roundup on what palliative care truly is.
So palliative care, so we say somebody's palliative when there's no longer any active treatment we can provide to make them better. But there is lots of things we can do to make them feel better. We can't cure their illness, we can't cure their heart failure, we can't stop them getting their dementia, but we can make the quality of life around them much better. And that can be sometimes the simplest things. It can be just making sure that they have really good access to personal care and they're eating well, and as people become less well, they're not so hungry, so it might be making sure that they've got food and drinks and little snacks throughout the day. It might be just making sure that their family are updated and included and visited. It can be anything which is about improving the quality of that person's life. And we know that when people become less well, their mobility is often one of the biggest things that's affected. So they don't leave the house as often, or they are unable to move around as much. So making sure that we can support doing things for them, and it might be doing their shopping, or supporting them with some virtual, if they like to join a club and they can no longer visit that club, can they access it virtually? And that's all part of this kind of holistic care, and it's really around the person, the patient, making sure that they're getting the best possible care around them right till the end of their lives. And a lot of it is common sense. It's not difficult. And I think when you do look at the care plans you're providing for residents, for service users, for people in your care, you're already doing a lot of this, and actually that is called palliative care. What we have done, unfortunately, is we've made palliative care a speciality and made everybody think, oh my goodness, we must refer to palliative care. But actually, when you unpick what it is for each person, it's different for everybody, and everybody can provide it in some format.
That's great, and thanks for kind of rounding that up, because I think a lot of the people that we have here today who are from home care agencies will understand completely that most of the things you spoke about, as you mentioned, are essentially a care plan. And by putting palliative care on this pedestal, I suppose there's kind of we must adhere to these certain guidelines, we must do this, whatever, when actually it's something that's being done already, and I think just brings to the forefront some ways that they can be more confident with it, is the aim of this session today as well. Now, I'm just going to head over here and change the slide over. And the next question that I have for you is, why is it important that care workers are trained in this area of palliative care?
Well, I think what you'll find is you'll know your residents, your service users, your clients better than anybody, because you're seeing them day in, day out, and you're going to notice those changes. So you'll be able to notice when they stop eating, when they stop drinking, or when they eat less, or when their mobility changes, or if their health changes, or those. And that's why it's really important that we empower those people working in frontline care to know what to do. And sometimes it is just picking up the phone and saying to their next of kin, I've just been to visit your mum today, and she didn't eat her breakfast, and she was a little bit bewildered and didn't seem as as alert as she usually does. I'm just a bit anxious, I'll be back tomorrow. And then if that family member can visit, maybe encourage them, and if they do need to get some advice from a GP or their community nurse or whoever their specialist is, then they can do that. But we know historically that a lot of these things, people very rarely just deteriorate really quickly overnight. There's often a trajectory where there's a few days or a few weeks where things are changing, and when people reflect on that, they'll say, oh yeah, they started having occasional accidents, or they weren't as continent, or no, they went off their food, or they stopped eating as much. And those little triggers, there's not necessarily a lot we might do, but just to know and communicate and share that, so that it's not a shock. And at 2 o'clock in the morning, when somebody starts becoming really unwell, we're trying to be proactive and not reactive. So we're trying to, if you notice a change, if you notice a difference in somebody, that you're communicating it, you're sharing it. And I know that one of the great things about Birdie is about how we can look at how we share those records and those care plans better amongst multidisciplinary teams, because that's how we can improve care for these people as well.
Yeah, definitely 100%. And what you were saying there really resonated with me from a Birdie point of view, because we're all about empowering the care staff to basically be the eyes and ears on the ground. And during COVID, it was never more apparent that care staff have a huge role to play in ensuring the health, the health and the well-being of their clients, because at times they may have been the only people that visited a client in their home. Because of COVID, for months they may not have been able to see anyone. So it really is key that we capture that. And it's not just because of COVID. At Birdie, we've always believed in this, and we've always believed in capturing those insights and helping to share them wider. But actually, COVID accelerated that and made it really apparent how important that is. And as you said, a lot of home care agencies are providing, care in their own home. They are doing palliative care already. But the point is now to really empower them so that they can make the decisions, they can help. And at the moment, they're a missing part of the puzzle, I think, when it comes to this whole integrated healthcare system. And it's just about bringing their insights and their knowledge to the forefront. And hopefully, with some of these resources, we can really help there. The next question that I have for you is obviously it's what can Marie Curie offer in this space, but also I think there's a question about ensuring that that healthcare assistants, that carers are adequately trained in delivering palliative care, no matter where that care is. And I think that ties into what Marie Curie can offer in this space.
Definitely. So to start with, I would advise you to have a look at our website. So we've got a palliative care knowledge zone on the website, and you can interact with it, play with it, share it with your staff. And a lot of it is like common sense kind of things, like, oh, my client had abdominal pain, were they constipated? Little things like that. Because a lot of it, is a palliative care, a lot of nursing. As people become less well, is common sense. There's that element that's still going to need specialist palliative care. They're going to need doctors to prescribe them medication. People who have cancer, we know, generally definitely have specific pain that will need specialist intervention. But for most people, as they become older or as they become less well and they're entering the last years of life, a lot of the symptoms they have are no different to a child who hasn't had their bowels open for a few days. What would you do with them? You'd give them, lots of fruit and lots of drinks, and you'd encourage them to, maybe try some laxatives, all of these kind of things. And I think the website is very general. And that's kind of the first thing I was going to suggest, is have a look at it. But also a lot of what you'll find in what you're already delivering is that you'll already have some carers who are really experienced in looking after people as they become less well, and actually sharing that learning locally, sharing that when you have your team meetings, bringing your staff together, reflecting on difficult situations. If you've had a patient who's been admitted to hospital and then brought out again, was there any learning you could do? What went well? What didn't go well? Sharing our knowledge. And what we know in care work is, I studied as a healthcare assistant, and I worked in the community. And when I did my nurse training, a lot of what I could reflect on was my experience of working with patients, and that takes time, so you can read all the books and you can look at all the websites. Actually, it's that experience. So using some of your more experienced care staff to buddy up and share their knowledge with your junior staff, and that's what I do in my service at Marie Curie. I bring in new healthcare assistants who they will have had some experience in end of life, but they might not necessarily have been with somebody who was dying on their own at night. I'd buddy them up with somebody. I'd let them go out and do some shadow shifts and rotations, and so they really learn from others, because actually caring is, you don't just learn it overnight. It's through doing it, isn't it? It's like anything in nursing and caring. You learn on the job, don't you? And going back to Marie Curie, all our stuff is free. We have got some really good stories and videos on our website too. And we also keep it updated with regular guidance. So through COVID, we had all the regular guidance. We've also got stuff about benefits. So we know that's really challenging, is financially, when people are unable to work and they need care. And there's so many things, and I'm learning all the time about new benefits and universal credit, and what people are entitled to. And if you get attendance allowance and you're on a low income, you can get a reduction in your council tax. People don't tell you all this information. You have to go and find it. But Marie Curie's website has everything there for anybody who's approaching the end of their life. So it might be, you can just say to the family, have you rung the information and support line at Marie Curie? Because although you're not imminently dying, they do deal with people who are in the last years of life and might need some support with finances, or what support is available. Also knowing what you've got locally. So you will have local hospices who will be, really keen to support and help you. And if there's any specific training you want, I'm sure they would, happily help. And again, they'd probably offer some shifts in their hospices or with their community teams for some of your staff to maybe go out and shadow, so they can be familiar and not be scared, because actually looking after somebody in their own home as they approach the end of their life is a real privilege. It's just as, for me, if I would say, compare it to a midwife, somebody being born, which is really, a special moment, actually being with somebody when they die, when they're comfortable and they're settled and they're in the environment they want to be, can be a real privilege to be with them. And if we can support people die where they want to, then that is, that can be just as rewarding.
I think that's actually a really lovely sentiment. I've not heard it referred to in that way, as like a midwife being born, and then you have the same kind of privilege as being with someone when they die. And actually, I think that's really, really lovely.
Especially if you've cared for them all that time as well. It would be really sad, wouldn't it, to see them go into hospital at the end when actually they've got all their things around them. And we know that people prefer to be at home. Most people.
Yeah, definitely. And we've seen that a lot through COVID, which we'll talk about a bit later, but just in general, people prefer it. And I think to kind of bring it back to something we just spoke about a minute ago, about empowering these care staff, especially for home care agencies, the ones who are sending care staff to visit people in their own homes, they're building such a bond with these people. And what we're talking about today is not about reinventing the wheel. It's not about, giving you a list of training that you have to go and complete, because as you said, Debbie, it's about learning on the go. And what we need to do, and I think what our duty is, with home care, is to empower the carers to, like you mentioned, not be scared, to give them the confidence, to know that, this is a really rewarding career to be in, and it's something that they should be proud of, and they should feel like they have the resources to help them do that.
Definitely.
I think it's lovely just the way that you sum that up. So thank you for putting it like that. Now I'm just going to hop on over here and change the slide over. Cool. So the next thing that we're talking about, which you kind of brought the discussion to a minute ago, is advanced care planning. I think a lot of home care agencies will be familiar with care planning in some sort, but I suppose advanced care planning, how would you kind of define that, and what should people be doing to make sure they're meeting advanced care planning wishes?
So advanced care planning is best done when somebody is well. So you don't want to wait for a crisis. You don't want to wait for it to be 2 o'clock in the morning where you're like, well, do you want to go to hospital? Do you want to stay at home? What do you want to do? So you want to have these conversations early on. And a lot of care providers in care homes, and I know in care agencies, you do this probably at the start of a referral when you're doing your initial assessment. But it's really important that it's revisited as things change, and that you're including those people around the person that you're caring for. So advanced care planning, if I was doing it with somebody and then I was writing it down on my care plan and keeping the care plan to myself, that's not going to help anybody. It would help me and it would help that person. But actually, it's making sure all those around know what that person's wishes are. And it's also being really realistic with them about what's appropriate and what's not appropriate. So, some people will say to me, oh, when I get really ill, I'd like to go to the hospice. And I'll be like, well, that's really nice. But actually, the hospice tend to take the more really symptomatic patients, and they don't get a lot of funding. So they're very particular about who they might take. So they might only take somebody for a couple of weeks. But if you're going to need long-term care, then we need to look at where that best is, and whether it's at home or whether it's in a care home, and who's going to be providing that care and who's going to be paying for it ultimately. But also talking to people about what they want. So some people, if you ask them, they'll say, there's no way I want to go to hospital. And so that's fine. But what if you got a temperature and we couldn't give you oral medication in the home? Would you want to go to hospital and have an intravenous, a needle in your arm and have medication given to you that way if you couldn't swallow it? Oh, maybe I'd want that. So it's having those conversations and then documenting it. So a lot of people, if they fell out of bed and broke their hip, of course they'd want to go to hospital, get their hip replaced, but then they'd want to come straight back home. And it's having those conversations about what would they want, what's realistic, and including their families. Because equally, the families would say, oh, actually, if that was the case, if my mum broke her leg, I'd give up work for a couple of days or weeks, whatever, and I'd help support. But I can't do it long term. But if it was something short term, I might be able to help. And I suppose it's all about communicating, talking things through, and trying to do it when people are well. Ultimately, the end question is, where would you want to be if you were dying? But there's lots of bits you get to before that. Often, people will have multiple hospital admissions before they become end of life, and those might be appropriate. But I think it's really important to visit. And if you were well enough, would you still want to come home, or would you want to be transferred to a care home if you needed 24-hour nursing care, or would you want to come home? But being realistic, because we know, don't we, that it's really hard to get district nurses visiting daily, let alone weekly, because they're really under-resourced as well. So it's being realistic. Who's going to provide that care? What care does that need? And sharing those plans.
I think it's really, really important in the sharing, and that's something we really advocate at Birdie, which is why we have, a family app that mirrors the things that you put onto Birdie, because we want families to be involved. But I suppose a question that I have for you, Debbie, as well, and this is one that came in on email before, was linked to advanced care planning. And they said, how often should you be having those conversations with either clients or families around advanced care planning? And I think, they might have had that conversation in the very beginning, when someone was, signed up for the home care agency. But then how frequently should they be doing that again?
Well, I would say at least every 6 months. And if the change in that person's condition is sooner, then have it then, because actually that person's, mobility changing or going to an outpatient appointment, say they've got some, lung problems and suddenly they start needing home oxygen. Well, that's a change in their condition, isn't it? So maybe now's the time to, it's going to be a bit less easy, isn't it, to take you out and about now you've got this oxygen that you need all the time. And what if you went to hospital? Would you, you're getting your oxygen at home, what else could we do to make things better for you at home? Or just all those things are triggers, aren't they? Any change in the care plan, that's when it's a chance to revisit the advanced care plan. Say they went from needing one person to get them up in the morning to needing 2 people to get them up in the morning and get them to bed. That's another opportunity to let's have an advanced care plan. Like you just would you'd revisit their care plan. You'd look at, is home still the right place? What else needs to be done? Is everybody around that person included? Is the GP aware? Do they have a social worker or community nurse? Are they aware that the plan's changed? Are they aware that now they need 2 people to help them move around the house? Those things, because we're only as good as what we know. And as in healthcare and social care, if you don't have that information, you're kind of setting your colleagues up for failure as well, aren't you? So sharing information all the time, really important.
Yeah, no, we definitely couldn't agree more. And I think that's a really good point, to update this information whenever something changes. And if something hasn't changed, then review it every 6 months at the minimum. I think a lot of our home care agencies, well, the ones that we have signed up to our platform, so our partner agencies, are encouraged to review a care plan every 90 days. That doesn't mean they have to make any changes. They just have to take a look at it and, check that everything is going according to plan. And I think, with the advanced care planning, that would be good practice as well. And, at the longest, every 6 months would definitely be ideal for this one. Cool. So the next question ties into advanced care planning again. And we've just spoken about, what you need to do to be on top of advanced care planning. But who exactly is responsible for advanced care planning, and who else should be supporting it? Debbie, if you could let us know that would be great.
Well, I mean, ironically, we would say I would be responsible for my own end of life care, but then I've got full capacity. I work in health and social care, so that kind of puts me on the back foot. But for people who we're looking after, they're probably quite vulnerable and they're already, needing our care. So there will be a specialist or somebody maybe who's taking charge, a key worker. Now, whether that is their social worker, their GP, their community nurse, you'd hope that they would take the lead. And if they don't, as their care provider, then that's something you can facilitate and ask and say, could we set up a meeting to have an advanced care plan? And it's not meaning that you're going to be responsible for that, but you can definitely facilitate it, because as the care provider, you'll know who all the people around that person are really important. So it might be actually that person you go and care for every day, actually the closest person to them is their next door neighbour who's been their next door neighbour for 50 years. And actually it might be helpful to have a include them in some advanced care planning. Or it might be a family member who's miles away, and actually you can do that by phone. Everybody is responsible. Though we'd hope in health and social care that there'd be somebody who would be a kind of key worker or a lead, a social worker. Unfortunately, due to resources, sometimes people just don't have the time, and they kind of say, "Oh, obviously, that person's fine at the moment. It's not urgent to have an advanced care plan." But I would argue, actually, it is, because they're already needing care. So, they're not going to, get better. They're not going to suddenly stop needing care. So, making sure that you can definitely lead on it, facilitate, and if it's not you who wants to lead it, then you can ask somebody else to lead on it, or you can speak to family and friends. There's loads of documents you can get families to download. In London, we've got a database called coordinate my care, and there's a patient portal called My CMC. So people in London can access that. In other parts of the country, there's paper documents people can fill in. You can download stuff off the internet, but obviously it's better if it's done, you know, by a team of people who are looking after that person.
No, for sure, makes total sense. And just the one you mentioned, Coordinate My Care, I'll share a link to that after the event in the follow-up email, so you've got that, and obviously, of course, the links to these slides, the knowledge base, and the recording of the webinar. Let's have a look. All right, so the next thing I have to cover here is we just spoke about, you know, what advanced care planning is and who should implement it. But I think a really, really important thing that I mentioned at the beginning is COVID-19. And of course, you know, it's kind of I suppose COVID is coming into every single conversation about anything ever at the moment, but it's especially important when it comes to care. And I touched on it very, very briefly, but it would be good, Debbie, to get your input into, you know, how COVID has changed the landscape for care and how you think it's going to affect palliative care.
Well, definitely. And I mean, you know, COVID taught us that actually anyone can be affected by death and dying, and it can be very quick and very sudden. And I think we'll see a lot more younger people thinking about death and dying. And we've seen a real uptake in our bereavement support for younger people who've maybe lost older relatives to COVID, and you know, asking for some bereavement support, and it's made them think about their own mortality. And of course, when we're thinking about our own mortality, we're thinking about, you know, what's important to us and where we want to be. And we've seen with COVID, obviously, the barriers of visiting people in hospitals and care home, which has obviously made people think more about being at home, and the challenges we've had delivering hands-on care, as you all have, you know, getting the PPE and getting into patients. And of course, because all our patients are vulnerable, they are a priority to get to and provide care to. So it's thinking as well, is there other things we can do? Befriending, so we've got volunteers, can they phone them up and support? I mean, obviously you can't get away from hands-on care for some people, they need it, you can't do that virtually, but there is a lot that we've learned through COVID, and I think it's made society in general think more about what's important to them and where they want to be. And I think we will see a real increase in people wanting to stay at home because, you know, they've seen the complexity of people being in hospital and being visited in hospital and care homes. You know, I mean, they're only just relaxing those restrictions now. You know, I mean, I expect that as a country, we'll be planning for more of these pandemics. And I think we also, as health and social care professionals, need to be thinking about how that will look for us. So I'm sure, like many of you, we had a lot of staff off sick, and we had to really prioritise the patients we cared for in the community. You know, who lives on their own, who definitely needs a visit tonight, and who actually lives with a family member, and actually maybe we could just phone them and offer some telephone support because we just don't have enough staff to go round. So yeah, so I think it's been a real game changer. And I mean, obviously we're waiting to see how the government announces about the health and social care reforms later on in the year, but hopefully it's for the better. You know, hopefully we will realise that you know, we are frontline services and just as important as the NHS, you know.
Yeah, for sure. And that is definitely something we're advocating at Birdie. And I think we've seen from the very beginning of COVID-19, as I mentioned before, you know, how important health and social care is. And it's just as important as any NHS worker. And actually, you know, hopefully with the reforms and with the way that technology is going, we can really bring kind of health and social care into the fold and be more integrated and work smarter and, you know, empower our teams, especially, you know, in all areas of health and social care, not just palliative care, but this is one area that's very, very important. Now, thank you for sharing all of that with us. that is it for all of my questions on my side. Now, I'm just going to see if anybody has any questions to ask on the chat box. If you do have a question, pop it in, and if not, then that means that we've been very helpful and clearly no one is confused. So I take that as a win. But if you have any questions, you know, after this event, after I've sent you your roundup email, please do feel free to just hit reply to the follow-up email. And if it's something I can answer, of course I will. If not, then I will get Debbie to help out. And I think the point is here, you know, it's all about supporting home care agencies and anyone in the care industry to provide the best care and really just be there as, you know, as a partner to help. So of course, any questions at all that come from this, please do let me know, and I will send you all a follow-up email with everything that you need in it. If I miss anything, again, just let me know. And I suppose all that's left to say, if nobody has any questions, is thank you so much, Debbie, for joining us. I think that was really, really informative, and I can't wait to share the resource with everyone. I think they're going to be really, really useful. And thank you to everyone who joined today. I hope you enjoyed it. If you have any feedback, of course, please let me know. And as I said, I will send you all a copy of everything we discussed here very shortly, hopefully by the end of the day. We'll announce our next webinar really soon, so just keep an eye on your inbox for that. But until then, that is all from me and Debbie. So thank you once again, Debbie. That was really, really useful.
Thank you. Thanks, everybody. Thanks for tuning in.
Right, I'm going to end the session. Say goodbye to everyone.